Hello friends, today I will discuss remaining part of guideline. Today's discussion will be tuberculosis treatment and tuberculosis preventive treatment in pregnant women living with HIV. Also discussed about tuberculosis preventive treatment and treatment of tuberculosis disease among infants. Now tuberculosis with HIV in pregnancy. Women who are pregnant or up to 6 months postpartum are at increased risk of developing tuberculosis disease. Pregnant women living with HIV are at particular risk from tuberculosis. Women living with HIV who develop tuberculosis disease in the postpartum period are twice as likely to die during the year following the birth of their infant than similar women who did not develop tuberculosis. Their infants are 3 times more likely to die during their first year of life and more likely to become infected with HIV. All pregnant women with tuberculosis should be screened for HIV if their HIV status is unknown. Now, tuberculosis preventive treatment in pregnant women living with HIV. The increased risk of tuberculosis among pregnant women who are living with HIV and the increased likelihood of maternal and infant mortality among women living with HIV who develop TB has led WHO to make the following recommendations. Pregnant women living with HIV in whom tuberculosis disease has been excluded should receive tuberculosis preventive treatment as part of comprehensive package of HIV care. This should be done regardless of whether the women are on antiretroviral treatment, irrespective of the degree of immunosuppression, and even if testing for tuberculosis infection is unavailable. In settings of high tuberculosis transmission, pregnant women living with HIV who have an unknown or positive test for tuberculosis infection and who are unlikely to have tuberculosis disease should receive at least 36 months of isoniazid preventive therapy. This should be given whether or not the woman is on antiretroviral therapy and regardless of her CD4 count or history of previous tuberculosis treatment. Pregnant women living with HIV should be screened for tuberculosis disease at every visit to a healthcare facility or contact with a health worker. These women should be screened using the 4-symptom screening method which I have mentioned in detail in my previous video. Pregnant women living with HIV who are not found to have tuberculosis disease should receive tuberculosis preventive treatment regardless of the stage of pregnancy. Tuberculosis preventive treatment in pregnant women living with HIV should utilize medicines that are considered safe in pregnancy. Tuberculosis preventive treatment improves pregnancy outcomes both in women living with HIV and their infants. Women can be treated with 6 months of daily isoniazid monotherapy or 3 months of daily rifampicin plus isoniazid or 4 months of daily rifampicin monotherapy. The risk of morbidity and mortality to mothers and infants due to the progression of tuberculosis disease outweighs the risk of adverse effects from these medicines, including the risk of liver toxicity. This advantageous benefit to risk balance also applies to prolonged 36-month tuberculosis preventive treatment with isoniazid. There are not enough data on the effects of rifampicin during pregnancy to recommend rifampicin containing regimes. An affordable regime that is particularly helpful for pregnant women living with HIV exposed to other opportunistic infections is the use of a fixed dose combination containing isoniazid 300 mg plus pyridoxine 25 mg plus sulfamethoxazole 800 mg plus trimethoprim 160 mg. Now checking baseline liver function test in order to screen for possible liver toxicity is encouraged where feasible, but is not essential. Routine liver function testing during pregnancy is not necessary unless there is a risk of liver toxicity. Vitamin B6 supplements should be given when possible to all women on an isoniazid containing regime. If this supplementation is unavailable, however, it should not prevent tuberculosis preventive treatment administration. With regard to prevention of multi-drug resistant tuberculosis among pregnant women living with HIV, not enough data are available to recommend a regime. However, levofloxacin may be used if the benefit is considered to outweigh potential harms. Now this is the recommended tuberculosis preventive treatment regimes for drug susceptible tuberculosis in pregnant women living with HIV. These I have briefly discussed here in this table. The regime, its dosage and additional concentrations are given. For 6 months of daily isoniazid, dosage is 5 mg per kg per day, and if available, given with vitamin B6 10 to 25 mg daily for duration of tuberculosis preventive treatment. Second regime is 4 months of daily rifampicin and its dose is 10 mg per kg per day. Third regime is 3 months of daily rifampicin plus daily isoniazid. Rifampicin 10 mg per kg per day and isoniazid 5 mg per kg per day. If available, give vitamin B6 10 to 25 mg daily for duration of tuberculosis preventive treatment. Now, 36 months of daily isoniazid, the dose is 5 mg per kg per day and should be given only in areas of high tuberculosis transmission. If available, give vitamin B6 10 to 25 mg daily for duration of tuberculosis preventive treatment. Now, monitoring and evaluation. Pregnant or postpartum women on tuberculosis preventive treatment should be monitored routinely at monthly encounters with healthcare workers. Checking baseline liver function test when isoniazid containing tuberculosis preventive treatment is given in pregnancy is strongly encouraged when feasible, but is not essential unless there are other risk factors for liver toxicity. For women with abnormal baseline test results, clinical judgment is required to ensure that the benefits of tuberculosis preventive treatment outweighs the risk. Liver function should be tested routinely in women with abnormal results. Appropriate laboratory testing should also be done for women who develop symptoms while on treatment. For example, liver function test for those with symptoms of liver toxicity. Women should be asked to contact a health worker at any time if they develop symptoms such as loss of weight, nausea, vomiting, abdominal discomfort, persistent tiredness or weakness, dark colored urine, pale stools, jaundice, confusion or drowsiness while on medication for tuberculosis. If a health worker cannot be consulted at the onset of such symptoms, the patient should stop treatment immediately. In people on multi-drug resistant tuberculosis preventive treatment, close monitoring for adverse effects and adherence to treatment is essential. Adverse effects from medicines depend on which preventive treatment regime a woman is on. Vitamin B6 supplementation in pregnant women undergoing isoniazid containing tuberculosis preventive treatment should be prescribed if available to prevent neuropathy. If neuropathy develops, vitamin B6 at a different dose may be given to treat it. Now, education and training. Countries should review and update their policies, standard operating procedures, and training curricula as necessary to support adaptation and adoption of the new antenatal care recommendations. Screening for tuberculosis and assessment for tuberculosis preventive treatment should be integrated into a country's antenatal and postpartum care algorithms. Education regarding tuberculosis in pregnancy should be incorporated into the curriculum of all health workers and community health workers who provide care to pregnant women. Depending on the structure of the antenatal and postpartum care, community health workers should be educated about tuberculosis during pregnancy and know how to properly refer women, as they may be the workers that pregnant women see most often and are most comfortable talking with. Pregnant women should also be educated about tuberculosis when visit their doctor. Education can also be done through social media, through pamphlets. Now, tuberculosis preventive treatment and treatment of tuberculosis disease among infants. Although this comes under the domain of pediatrics, but as gynecologist, if patient has untreated tuberculosis or treatment started but still chances of transmission of infection to baby, it is our duty to timely refer to pediatrician for better outcome. Infants have high risk of developing tuberculosis disease if exposed to someone who has pulmonary tuberculosis. If the infant's mother has untreated pulmonary tuberculosis, when the infant is born, the infant should be screened for tuberculosis. Symptoms of tuberculosis in an infant are different to those in an adult. In addition to the usual symptoms of tuberculosis in adults, which are cough, fever, night sweats, and weight loss, infants may not be eating well, may fail to adequately gain weight instead of losing weight, and may fail to thrive and have reduced playfulness or are greater tiredness. Infants may not cough at all. It is also important to look at infants' growth chart to see if they have been losing weight or their weight has plateaued, which may indicate tuberculosis. Changes on the chest radiograph may be subtle and hard to see if the quality is not optimal. Infants frequently also have extrapulmonary disease, so health workers need to be aware of clinical features of tuberculosis outside the lungs. All infants, regardless of HIV status, who are contacts of a tuberculosis patient and who are unlikely to have tuberculosis disease, based on appropriate evaluation, should receive tuberculosis preventive treatment. This should be done even if the testing for tuberculosis infection is unavailable. Any infant found to have tuberculosis should be started on tuberculosis treatment immediately. Thanks for watching. If you like my video, please subscribe to my channel and click the bell icon for more updates.